what is pneumothorax? So actually, if there is any air in pleural cavity, this is defined as pneumothorax. So pleural cavity is the potential cavity between two layers of pleura, visceral and parietal pleura. Normally, in between the two layers of pleura, there is small amount of pleural fluid is present to lubricate the surface, but normally no amount of air is present in normal lung. But when it is pathological, then air may be accumulated inside the pleural cavity, what is called as pneumothorax. So pneumothorax can be classified according to two classification. First, according to its etiology, what is the cause of pneumothorax, and according to its mechanism, how it is produced. So according to etiology, it is broadly classified as spontaneous pneumothorax and traumatic pneumothorax. So what is spontaneous? That occurs without any trauma, history of trauma, occurs spontaneously. So spontaneous pneumothorax can be classified further into primary and secondary pneumothorax. So what is primary? If there is no underlying lung pathology, that is primary spontaneous pneumothorax. And what is secondary? If there is underlying lung pathology, this is secondary spontaneous pneumothorax. So, and another one is catamenial pneumothorax. This is also a cause of, also a type of secondary spontaneous pneumothorax. So actually, this is a broad division of pleural endometriosis, pleural seeding of endometrioma, which further ruptures into pleural space, causes catamenial pneumothorax. So the pneumothorax occurs in each and every cycle of the period or menstrual cycle. So this is called catamenial pneumothorax. Second is traumatic pneumothorax. Traumatic, that means there is a certain history of trauma behind the causation of the pneumothorax. So traumatic pneumothorax can be of iatrogenic and non-iatrogenic. So what is iatrogenic? Iatrogenic means if during the procedure you may introduce the pneumothorax during any procedure. Suppose there is pleural fluid in pleural cavity, so you have to aspirate the pleural fluid. At that time, you maybe punctured the pleural, another pleural space, causing a potential area of entry of air from the outside, causing a pneumothorax. This is iatrogenic pneumothorax. Or there may be a lung mass that is not touching the pleura, but somewhat inside the pleura and the lung cavity. একটু ভেতর দিকে মাস আছে. So in case of, if you doing a FNAC or a biopsy, then the biopsy needle may puncture the pleura and lung parenchyma as well, which may cause iatrogenic pneumothorax. And another one is, which is called as artificial or therapeutic pneumothorax. What is that? Artificial pneumothorax. In old age, where there is no anti-tubercular drug to treat or cure the TB, in old days, so কি করা হতো না, এই basically এই Mycobacterium tuberculosis is aerophilic, which loves to gather the oxygen, right? So previously it was introduced that if we introduce air in the pleural space and parenchyma, because of the air, the parenchyma is compressed, so there is less oxygen and the aerophilic mycobacterium may die. So which may cure the Mycobacterium tuberculosis. But this is not practiced nowadays. This is called artificial pneumothorax. And non-iatrogenic one, which it is the most common cause of traumatic pneumothorax. Non-iatrogenic may be a blunt injury, may be a sharp injury. Also, iatrogenic pneumothorax may occur in patient receiving mechanical ventilation or positive airway pressure. If we receive the positive airway pressure, so after a certain amount of time, the positive pressure accumulates inside the alveoli, which may lead to rupture of the alveoli. This is another traumatic or iatrogenic pneumothorax. So this is classification of pneumothorax according to its mechanism. One is closed, second is open, and third is tension pneumothorax. What is open pneumothorax? Just concentrate on the name of the pneumothorax. It is open pneumothorax. Why it is open? If you stab a person, so there is an opening and there is a potential connection between the air environment and the pleura. This is open pneumothorax. This is one way, and two-way valve. So if in case of inspiration the air accumulates, and in case of expiration, as the opening is potential one, so the in case of expiration the air comes out through the from the pleural space. So this is a open pneumothorax. That's why open pneumothorax এর সাইজ কিন্তু খুব একটা বড় হয় না, বিকজ এটা কন্টিনিউয়াসলি ইভলভ করছে, মানে ইন্সপিরেশনে ঢুকছে আবার এক্সপিরেশনে বেরিয়ে যাচ্ছে। Second one is closed pneumothorax. When there is no history of trauma, and there is no potential communication between the environment or the pleura, the pneumothorax occurs due to rupture of any air space, any alveoli or bulla or bleb. So there is no communication or no trauma, right? So this is called closed pneumothorax. And last one is tension pneumothorax. When there is a valve-like action, so there is a potential valve-like action due to trauma or due to mechanically ventilated patient. So there is one-way valve. Air enters into the pleural cavity during the inspiration, but cannot escape the pleural cavity in expiration. Why? Because the one-way valve blocks the pleura during the expiration. So there is accumulation of the air, just not like the open pneumothorax. Open pneumothorax এ একটা ওপেনিং থাকে যেটা দিয়ে ইন্সপিরেশনে ঢোকে, এক্সপিরেশনে এয়ার পাস আউট হয়। দ্যাটস ওয়াই ওখানে খুব একটা এয়ার অ্যাকুমুলেট করতে পারে না। ইন কেস অফ টেনশন pneumothorax, as this is a valve like action, so just ইন্সপিরেশনের সময় ভালভ ওপেন হয়, এয়ার এন্ট্রি হয়, বাট এক্সপিরেশনের সময় কিন্তু ভালভ ক্লোজ হয়ে যায়। সো তার জন্য কি হয়, there is a pneumothorax in tension, so much air in tension. This is called tension pneumothorax. This is a medical emergency. Tension pneumothorax is a medical emergency. Next, what is the pathophysiology of pneumothorax? So just think of a elastic spring. একটা স্প্রিং যদি তুই ভার্টিক্যালি সাসপেন্ড করিস তাহলে কি হবে, ভার্টিক্যালি স্প্রিং সাসপেন্ড করলে কি হবে, the upper part of the spring has the highest tension than the lower part because of the weight, because of the gravity. Just lung has a tendency to recoil, so imagine lung as a spring. তাহলে কি হবে, lungs যদি gravity dependent হয়, so the upper part of the lung has got maximum tension, has got maximum shearing tension. So এই যে টেনশনের ডিফারেন্সটা হচ্ছে, প্রেসারের ডিফারেন্সটা হচ্ছে, এইটার জন্য কি হয়, এই যে আপার পার্ট অফ দ্য লাং, তাতে ইলাস্টিক রিকয়েলের জন্য, টেনশনের জন্য ড্যামেজ অফ দ্য প্লুরা অ্যান্ড প্যারেনকাইমা, রাইট? সো ইট ইজ কন্টিনিউয়াস প্রসেস, আমাদের সবারই কিন্তু এই ড্যামেজটা হচ্ছে। সো ইন কেস অফ smokers, in case of long and thin person, the tension is more because of the height, right? So, and if the patient smokes, then due to smoking, এটার জন্য reactive oxygen species production হয়, that leads to continuous inflammation and wearing and tearing of the rest of the parenchyma and pleura. That leads to accumulation of the air in small pockets, that is called bleb or subpleural bleb, that is in the location at subpleural space. Bleb in subpleural space. So rupture of the bleb in subpleural space is the cause of or pathophysiology of primary spontaneous pneumothorax. This is not secondary spontaneous. So apex pressure is more negative than base, and so this is the cause of spontaneous pneumothorax, and the communication develops between the alveoli and pleural space. So এই যে কমিউনিকেশন ডেভেলপ হচ্ছে বিটুইন দ্য অ্যালভিওলাই এন্ড প্লুরাল স্পেস, আনটিল এন্ড আনলেস the pressure difference of the both alveoli and the pleural space is same, ততক্ষণ কি হবে, এয়ারের একটা এন্ট্রি চলবে, that causes more disruption of the alveolar wall and more disruption of the lymphatics and other structures of the alveoli. So rupture of the cavity, so this is another reason of pneumothorax, but this is due to in case of secondary pneumothorax, rupture of cavity. So what is cavity? What is a cavity? What is a cavity? What is a cavity? So potential air containing space where there is a additional inflammation, right? So this is a cavity. So rupture, so cavity kothay hoy? What are the causes of cavitary pneumonia? Most common is tuberculosis. Second most common. So there are the other causes of cavitary pneumonia. First is TB, second is staphylococcal pneumonia, third is Pseudomonas, Klebsiella, Pneumocystis cerevisiae. So these are the causes of cavitary pneumonia. So in those cases, if the cavity ruptures after chronic inflammation, then the air inside the cavity may get into the pleural space, causing a secondary pneumothorax, right? So this is the picture. That this is the bronchosvascular sheath, right? So these are the alveoli. So in case of pneumothorax, there is a potential space between the alveoli and the pleura. So এই যে এখানে এয়ারটা অ্যাকুমুলেট হচ্ছে, that leads to disruption of the arteriole, bronchiole and the venule, right? So this is pathophysiology of pneumothorax. Second, what would be the physiological effects of pneumothorax? Mostly this is not in case of small pneumothorax, this is in case of moderate or large pneumothorax. So what happens in case of moderate or large pneumothorax? That is the, if the pneumothorax occupies at least more than 1/3 of the pleura or lung space, then it is called moderate or large pneumothorax. In that case, the vital capacity of lung will be reduced, as well as the total lung capacity and functional residual capacity. So these three capacities will be reduced, right? So what is vital capacity? What is vital capacity? Physiology. What is vital capacity? No. Just explain, God. What is the definition of vital capacity? So it is forceful expiration, after forceful expiration, after forceful inspiration, right? The total lung capacity. This is called vital capacity. So vital capacity will be reduced because of the compression of the air. So 1/3 of the volume of the lung is occupied by the air. Naturally, the vital capacity and the total lung capacity will be reduced. So next, so if the pneumothorax is large, greater than 20%, the oxygen concentration, partial pressure of oxygen will fall immediately. Initially, what happens? So suppose there is an area of pneumothorax. In this area, there is no ventilation. So if you calculate the VQ, V is 0 and Q, perfusion is still present. So VQ is 0. This is called a shunt. So what is shunt and what is dead space? This is also, so in case of dead space, there is no perfusion. In case of shunt, there is no ventilation. So VQ is infinity in case of dead space, but in case of this one shunt, the VQ is 0. So in pneumothorax, there is presence of shunt where VQ is 0. This is the initial cause of hypoxia. But if it is not a large pneumothorax or it is not a secondary spontaneous pneumothorax, compensatory vasoconstriction occurs at the later stage, which abolishes the VQ mismatching. But this is not in case of secondary spontaneous pneumothorax, because in case of secondary spontaneous pneumothorax, the lung parenchyma is already damaged by COPD, by other chronic lung disorder. So, and furthermore, this pneumothorax is causing another VQ mismatch. So, these two VQ mismatch cannot be eliminated by only vasoconstriction in case of secondary spontaneous. That's why যখন কোনো secondary spontaneous pneumothorax এর patient আসবে তখন খুব small amount of pneumothorax হলো তার কিন্তু symptoms will be more than that of the primary spontaneous pneumothorax, right? So in tension pneumothorax there is increased intrathoracic pressure. Why? Because there is continuous accumulation of the air inside the pleural cavity, but the air cannot move out from the thoracic cavity. So there is, because of the tension, there is increased intrathoracic pressure, mediastinal deviation, and cardiac apex deviation. Further reduces the cardiac output and venous return, which may lead to myocardial injury and heart failure. So that's why tension pneumothorax is a medical emergency. Now, primary spontaneous pneumothorax. So, what is the etiology? Just আমি এক্ষুনি discuss করলাম যে etiology, because of the shearing force at the apex, there are production of many subpleural blebs. So, rupture of the subpleural bleb is the primary pathogenesis of the primary spontaneous pneumothorax. So, কাদের primary spontaneous pneumothorax হবে? Long, thin, tall, smoker, and preferably in the age group between 20 to 40 years. তাদের কিন্তু primary spontaneous pneumothorax এর চান্স বেশি হবে. So this is very important. The rate of recurrence after a primary spontaneous pneumothorax same sided. Suppose একটা পেশেন্টের 1 year ago রাইট সাইডে একটা প্রাইমারি স্পন্টানিয়াস নিউমোথোরাক্স হয়েছে, তার কিন্তু রেকারেন্সের চান্স হচ্ছে অ্যারাউন্ড 25% in the next 2 years, right? But this is not in case of secondary spontaneous, because secondary spontaneous pneumothorax the recurrence rate is as high as 50%. First episode after 1 year there may be another episode of pneumothorax. So there may be some genetical association. So primary spontaneous is sporadic. Most commonly these are sporadic, but the genetic association are, the most common association is Barth-Hogg-Dubé syndrome. What is that? This is a mutation of FLCN gene. So FLCN is a tumor suppressor gene, right? So if you mutate the FLCN gene, there are plenty of production of renal tumors, but they are benign. Renal tumors, skin tumors, as well as pneumothorax due to production of subpleural bleb. So this is autosomal dominant in nature, Barth-Hogg-Dubé. Second one is Ehlers-Danlos syndrome. So what is that? Ehlers-Danlos syndrome. It is a deficit in collagen. There are 3 collagen deficit, 1, 3 and 5. আমার মনে পড়ছে না, মনে এই তিনটেই হয়, but the most common is collagen 5. There is the production of collagen 5 is hampered. That's why there is the elastic recoil of the tissue is lost, right? That produces pneumothorax. Ehlers-Danlos. Third one is Marfan syndrome. So Marfan syndrome due to mutation of which gene? Marfan syndrome? Very good. Fibrillin gene or FBN1, right? Fibrillin gene. And alpha-1 antitrypsin deficiency. This is in case of but in case of alpha-1 antitrypsin deficiency, there is also production of pan-acinar emphysema. So rupture of the emphysematous bulla and the subpleural bleb can occur in alpha-1 antitrypsin. So alpha-1 antitrypsin can cause both primary and secondary pneumothorax. So what will be the symptoms of pneumothorax? Primary spontaneous pneumothorax. Primary symptoms, there is tall, thin, built, young smoker, sudden onset, pleuritic chest pain with shortness of breath. So this is, but just এটা খুব মাথায় খুব ইম্পর্টেন্ট, the shortness of breath is not as just the shortness of breath is proportionate to the size of the pneumothorax. If the pneumothorax is large, then the shortness of breath is more. Unlikely in case of secondary spontaneous, যেখানে কিন্তু খুব small pneumothorax ও খুব বেশি shortness of breath হবে. So mostly develops at rest. And what will be the clinical signs of pneumothorax? What we would see in percussion? So there is hyperresonant note on the affected side. Right? What will be in auscultation? No, that is wrong. Diminished or unequal breath sound, not absent. Yes, absent breath sound may occur, but that is not a pathognomic feature. The pathognomic is unequal breath sound, Right side breath sound is normal, but left side is less. So there is a chance of pneumothorax. So this is the ECG feature. Why? So this is actually the ECG features specially seen in case of tension pneumothorax, not the other pneumothorax, because of the tension pneumothorax, the cardiac axis will be rotated clockwise. That's why there is right axis deviation, followed by the decreased R amplitude and T wave inversion because of the relative ischemia of the myocyte. Also, this is the X-ray. So can we appreciate? দেখতে পাচ্ছিস এখান থেকে দেখা যাচ্ছে? So this is the left sided pneumothorax. So how do you identify pneumothorax in X-ray? There are certain points. First, there is hyperlucency, absent bronchovascular marking in the affected site. Third thing is, the most important is, there is prominent visceral pleural margin. This is called visceral pleural line. দেখতে পাচ্ছিস, এই যে এখানে দেখতে পাচ্ছিস, this is visceral pleural line, that C-shaped, this is visceral pleural margin. So this is convex, right? And this is called fist sign. So the collapsed lung is at the hilum, like a fist. So this is called fist sign of the collapsed lung. This is a case of pneumothorax. But is this a case of pneumothorax? These two pictures are of pneumothorax? No, this is not a tension pneumothorax. This is a bulla. Why? Because see the margin is concave. This is concave margin. This is bulla. This is not a pneumothorax. Pneumothorax always have a convex margin, but giant bulla have a concave margin. So this is giant bulla syndrome. Okay, next very important thing is, how do you measure the pneumothorax? This is important because to prognosticate the pneumothorax, and how do you treat the pneumothorax accordingly, right? So the measurement of pneumothorax can be defined by two methods. First is ATS method or American Thoracic Society method. Second is BTS method, that is British Thoracic Society method. So ATS method, what does it signify? ATS method, this is the apex to cupular distance, lung apex to cupular distance. So the margin will be calculated. This is called apex cupular distance. So this is in case of pneumothorax, large pneumothorax, it must be more than 3 cm. But যেটা আমরা ইউজ করি, which is recommended in guidelines to use the BTS guideline, right? So BTS guideline at the level of hilum, you measure the intrapleural distance. So if the intrapleural distance at the level of hilum is more than 2 centimeter, then it is a large pneumothorax. So মনে রাখবি just 2 centimeter মনে রাখতে হবে, 3 টা দরকার নেই. This is again a bulla, concave margin, and this is USG finding ultrasonographic, bedside ultrasonographic finding of pneumothorax. In case of normal lung, there is, what is seashore sign? There is presence of seashore sign. What is that? What is seashore sign? Yes, the two pleurals are rubbing each other. That means this is seashore sign. So, but if there is accumulation of air inside the pleural cavity, there will be barcode sign or loss of seashore sign. And there are another two signs, lung point, lung sliding. So these are the other two signs of pneumothorax, USG signs of pneumothorax. But most importantly, what is the investigation of choice or confirmatory investigation of pneumothorax? This is the CT thorax, HRCT or CT thorax. Next, management of primary spontaneous pneumothorax. So this is according to the BTS guideline. If the pneumothorax size is small, that is less than 2 centimeter, then you should observe the patient. And there is no hemodynamic compromise. You should observe the patient with supplementation of 100% FiO2, 100% oxygen. Why? What is the mechanism behind it? What is the mechanism behind giving 100% O2 in case of pneumothorax? Because in case of pneumothorax, what happens? This is the environmental air, right? So environmental air, in case of pneumothorax, consists more nitrogen than the oxygen. So there is 75 to 78% nitrogen and 21. This is the constituent of the environmental air, right? 78% nitrogen, 21% oxygen, and the other 1% are the other gases. So, but if you give 100% oxygen in a case of pneumothorax, তাহলে কি হবে? Oxygen 100% হলে the oxygen displaces the nitrogen inside the pleural cavity. ঠিক আছে? So pleural cavity তে nitrogen আছে 78%, suppose তুই অক্সিজেন দিলি বাইরে থেকে 100% FiO2. সো এই 100% FiO2 ক্যাপিলারিতে গেল, ক্যাপিলারিতে গিয়ে ওখানে অ্যালভিওলাইয়ের যে নাইট্রোজেন ছিল সেটাকে ওয়াশ আউট করে দিল. সেখানে এখন কি কনসেন্ট্রেশন? মানে নাইট্রোজেন কনসেন্ট্রেশন ইজ ভেরি লো, and in case of pleural space, in case of pneumothorax occupied pleural space, the nitrogen concentration is higher. So there is a pressure difference. This higher from the air moves from the higher to lower gradient absorption of the pneumothorax. In case of small pneumothorax in less than 2 centimeter size. So even if the oxygen reduces pneumothorax at least 1.2% daily, right? But you have to observe the patient very carefully. If in between the therapy, if the patient develops shortness of breath or tachypnea or tachycardia or hypotension, then you must intervene. So second thing is aspiration. So if the size is more than 2 centimeter and symptoms, odd symptoms, actually plus minus symptoms, after initial management, after giving oxygen, you have to draw the you have to aspirate the air. So the most important site is 5th intercostal space for aspiration. You have to attach a 16 gauge needle to a 60 ml syringe, and there is the how do you confirm there is a presence of pneumothorax? If there is sudden loss of resistance. Second, যদি সিরিঞ্জে তুই কোনো ডিস্টিলড ওয়াটার নিয়ে অ্যাসপিরেট করিস, there is accumulation of bubble in the syringe. So that's how you can confirm there is pneumothorax. But very importantly, if you aspirate continuously for more than 4 liters of pneumothorax, then this is the indication of putting a chest drain, right? So this is not a small pneumothorax. So if the air is continuously aspirated for more than 4 liters, consider giving a ICT or intercostal tube. Next, intercostal tube drainage or tube thoracostomy. So what are the indications of tube thoracostomy? In case of, this is in case of primary spontaneous. In all cases of secondary spontaneous pneumothorax, you have to give the ICT. But in case of primary spontaneous pneumothorax, if there is failure of aspiration, যেটা আমি আগের স্লাইডে বললাম, if the size of the pneumothorax is 2 cm plus symptom or hemodynamic compromise, if there is presence of tension pneumothorax, or if you want to do a pleurodesis. So what is pleurodesis? So these are the indications of tube thoracostomy. What is pleurodesis? Actually, if there is a potential space between two pleura, then there is a chance of reaccumulation of the air. If you obliterate the pleural space by any inflammation, any external inflammation, then you can reduce the chance of recurrence of the pneumothorax, right? So after, what is the procedure of doing an ICT? তোরা দেখেছিস ICT করা? আমি করেছিলাম, দেখেছিস তো? So just like that, কিছু ব্যাপার নয়. After confirmation of the pneumothorax, you have to locate the safety triangle. So what is the boundary of the safety triangle? Latissimus dorsi, pectoralis major, apex of the lung, and 5th intercostal space. So this quadrangular space is, or triangular space is safety triangle. Why we choose safety triangle to give ICT? Because it avoids injury to the neurovascular bundle, right? Next, locate the safety triangle and always do antiseptic dressing and draping. After that, you have to give local anesthetic, lignocaine. So this is the procedure of giving local anesthetic just above the upper border of the rib to avoid the injury to the neurovascular bundle. So কি করবে, অ্যানাস্থেসিয়া এমন ভাবে করতে হবে যাতে পেশেন্টের পেন কম হয়. You are giving a local anesthesia. Just this is a regional block kind of anesthesia. So after giving anesthesia, you have to choose the pigtail. Have to give a pigtail catheter, 10 to 14 French of pigtail catheter, right? In case of primary spontaneous pneumothorax, there is no use of giving a ICT or intercostal large bore intercostal tube, because it is more traumatic. Intercostal tube are recommended if in case of secondary spontaneous, in case of tension pneumothorax, or if you do a pleurodesis. So in case of primary spontaneous pneumothorax, always choose the smallest size of pigtail catheter, 10 to 14 French of pigtail catheter, and a small incision is made in the skin usually between the ribs, and a blunt dissection with a forceps to dissect the muscle and tissue to reach the pleural space. So chest tube is placed and secured by giving a suture. The other end of the tube is connected to water seal drainage. So what is the mechanism of connection of the tube to the water seal drainage? আমি তো ওপেন এয়ারে রেখে দিতে পারতাম টিউবটাকে, কেন? what? Because one way valve, very good, this is a one way valve, because যদি আমি টিউব দিই তাহলে কি হবে, দেখ বেসিক্যালি নর্মালি intrapleural pressure is negative. It is mostly between -4 to -8 centimeter of H2O. But if there is air inside the pleura, then the pleural pressure is somehow positive. মানে যেটা আমাদের ক্যালকুলেশন করে দেখা গেছে যেটা pleural pressure in case of pneumothorax is between +2 to +4 centimeter of H2O. So there is positive pressure, and if you attach the water seal drainage, and water seal টা কত দূর করতে হবে, কত দূর আমাদের ওয়াটার ফিল করতে হবে, 2 সেন্টিমিটার অফ H2O ওয়াটার, বিকজ উপরের প্রেসারটা যদি 4 সেন্টিমিটার হয়, নিচের প্রেসার যদি 2 সেন্টিমিটার হয়, তাহলে কি হবে, তাহলে হায়ার টু লোয়ার গ্রেডিয়েন্টে মুভ করবে the pneumothorax, the air. This is the basic of giving a water seal drainage. And যেটা ও কারেক্টলি বললো, this is actually a case of one way valve. In case of মানে this is a one way valve, আমি যখন টিউব দিচ্ছি তখন এয়ার আসছে আমার এখানে, বাট মানে ওটা আবার রিভার্ট ব্যাক করছে না ওখানে. This is a case of, this is one way valve. So how do you confirm there is presence of air in water seal drainage? Bubble, the confirmation will be most appropriately by seeing the swing of the air column. So there is swing of the air column. If there is presence of bubble in the fluid, that means there is continuous leaking of the air from the bronchus to pleura, causing a bronchopleural fistula. যদি কোথাও কোনোদিন দেখিস কোনো আইসিটি ব্যাগে কন্টিনিউয়াস বাবলিং হচ্ছে, দ্যাট মিনস there is a bronchopleural fistula. This is not a simple pneumothorax, because যখনই ড্রেন করছিস তখনই ব্রঙ্কাস থেকে এয়ারটা কানেক্ট হয়ে প্লুরাতে অ্যাকুমুলেট হচ্ছে. সো দিস ইজ pneumothorax before giving ICT, and this is after giving ICT. There is re-expansion of the lung. দেখতে পাচ্ছিস এখানে এই যে ICT টিউব, this is ICT. One of the most important question is how long you should allow the chest tube to remain in the place. কতক্ষণ তোরা বলবি কতদিন অবধি চেস্ট টিউব রাখতে পারবি. So after full re-expansion, after 24 hours of the full re-expansion of the lung. So how do you assess the re-expansion of the lung? First, symptom কি হবে? Shortness of breath will be decreased. Second, radiological signs, the presence of breath sound in the absent breath sound area or unequal breath sound area, and radiologically and percussion also the return of the normal percussion note, and radiologically by doing a X-ray or USG. And by seeing the air column, if the air column, the swing of the air column is less than 5 centimeter, then there is re-expansion, right, of the lung. But if the lung is not re-expanded in 4 to 5 days, then you must consider a thoracoscopy or thoracotomy, right? Next, pleurodesis. So what is pleurodesis? What is the goal of pleurodesis? It is the mechanical way of obliterating the pleural space, right? যদি pleural spaceটাকে আমি obliterate করতে পারি, that means সেখানে কোনো fluid or air এর accumulation further possible নয়. This is pleurodesis. So pleurodesis indicate, what are the indications of pleurodesis in pneumothorax? So first, after second episode of primary spontaneous pneumothorax, suppose একটা পেশেন্টের primary spontaneous pneumothorax হলো 1 বছর আগে, after 2 years আবার একটা primary spontaneous pneumothorax হচ্ছে same side of lung এ, তখন you must have to do a pleurodesis. But this is in case of primary spontaneous. In case of secondary spontaneous, the first episode of secondary spontaneous pneumothorax, you have to do a pleurodesis because the recurrence chance is as high as 50%. ঠিক আছে? Next, if there is bilateral pneumothorax, patient এর bilateral pneumothorax আছে, তখন তাকে প্লুরালিসিস করতে হবে। অ্যান্ড ইন কেস অফ প্রাইমারি স্পন্টানিয়াস নিউমোথোরাক্স কাদের স্পেশালি ইন সার্টেন অকুপেশনস লাইক পাইলট অ্যান্ড ডিপ সি ডাইভার্স, যাদের কিন্তু প্রেসার ডিফারেন্স হয়, পাইলট আর ডিপ সি ডাইভার্সে প্রেসার ডিফারেন্স হয় লাংসে, তার মানে তাদের রেকারেন্সের চান্স আরো বেশি থাকবে, তো প্লুরালিসিস করতে হবে। সো দেয়ার আর টু টাইপস অফ প্লুরালিসিস, ফার্স্ট ইজ কেমিক্যাল অ্যান্ড সেকেন্ড ইজ সার্জিক্যাল প্লুরালিসিস। We prefer surgical pleurolysis over chemical pleurolysis in case of pneumothorax. Next, secondary spontaneous pneumothorax. So these are the etiologies of secondary spontaneous pneumothorax. Most common etiology is COPD or emphysematous lung field, and interstitial lung disease, other infections, cavitary pneumonia, tuberculosis, pneumocystis, zero VC, or primary lung carcinoma. These are the causes of secondary spontaneous pneumothorax. This is very important. Symptoms of secondary spontaneous pneumothorax is more severe than that of primary spontaneous pneumothorax because of the underlying VQ mismatch. The VQ mismatch is severe in case of secondary spontaneous pneumothorax. ঠিক আছে? So যদি small নিউমোথোরাক্স হয়, সেকেন্ডারি স্পন্টানিয়াস নিউমোথোরাক্সের শর্টনেস অফ ব্রেথ অর সিম্পটম কিন্তু খুব বেশি হয়। ঠিক আছে? সো হোয়াট ইজ দ্য ট্রিটমেন্ট অফ secondary spontaneous pneumothorax? This is the latest guideline. British Thoracic Society 2023 guideline recommends just to assess the symptom, not the size. যদি স্মল নিউমোথোরাক্স থাকে বাট সিম্পটম ইজ সিভিয়ার এনাফ, দেন ইউ হ্যাভ টু ইন্টারভিন। ঠিক আছে? নট গিভিং 100% অক্সিজেন টু এ সিওপিডি পেশেন্ট বিকজ দ্যাট উড লেসেন দ্য রেসপিরেটরি ড্রাইভ, ফার্দার অ্যাকুমুলেশন অফ দ্য কার্বন ডাইঅক্সাইড। So this is not a therapy of secondary spontaneous pneumothorax. Just straight away put the drain, chest drain. So in case of symptomatic SSP or large pneumothorax, দেখ এখানে কিন্তু পিকডেলের সাইজটা বড়, ওটাতে ছিল 10 to 14 ফ্রেঞ্চ, এটাতে হচ্ছে 16 to 18 ফ্রেঞ্চ, বিকজ এখানে কিন্তু এই নিউমোথোরাক্সে পেশেন্টদের ব্রঙ্কোপ্লুরাল ফিস্চুলার চান্স খুব বেশি থাকে, তাই তো? বিকজ অফ দ্য ক্রনিক ইনফ্লামেশন ব্রঙ্কোপ্লুরাল ফিস্চুলা ডেভেলপ করে। সো ব্রঙ্কোপ্লুরাল ফিস্চুলা যদি ডেভেলপ করে, if you give a small drain, then the fistula will not close. So to close the fistula you have to put a chest drain, but এটা ক্লোজ করার জন্য নয়, you have to do a pleurolysis also. ঠিক আছে? So 18 French pigtail, না 18 French সরু হবে, না এই যে এখানে দেখ দেওয়া আছে 28 French, 28 French মোটা, 18 French মোটা, 10 French মানে সরু। ইনসাইড দ্য ক্যাথেটারের মতো তো নয় এটা। So but if patient is in mechanical ventilation, always put a large bore ICT, ঠিক আছে? Surgical intervention is needed if there is no re-expansion after 3 days of putting a chest drain. So this is a chart of spontaneous pneumothorax management, and this is very important. কখন পেশেন্টকে বলবি এয়ার ট্রাভেল করতে, আফটার হাউ মেনি ডেজ অফ রিজলিউশন অফ দ্য নিউমোথোরাক্স? সো দ্য গাইডলাইন রেকমেন্ডস আফটার রেজলিউশন অফ দ্য স্পন্টেনিয়াস 7 days after resolution of the spontaneous pneumothorax or 7 to 14 days after resolution of the secondary spontaneous pneumothorax. So there are other categories of pneumothorax like pneumothorax in HIV. কেন এটা আলাদা অন্য নিউমোথোরাক্সের থেকে? This is also a secondary spontaneous pneumothorax, but most commonly the pneumothorax of the HIV is caused due to infection, chronic infection, pneumocystis pneumonia. So pneumocystis pneumonia occurs in HIV patients of CD4 count is less than 200, and most commonly the pneumocystis pneumonia occurs in upper part of the lung. That's why there may be incidence of upper lobe pneumothorax in case of PL-HIV. And obviously cavitary tuberculosis is another cause. So pneumothorax is in lamb or lymphangioliomyomatosis. What is that? শুনেছিস? LAM মানে জানিস? What is LAM or lymphangioliomyomatosis? Tuberous sclerosis শুনেছিস? So it is associated with TSC, tuberous sclerosis. The proliferation of the smooth muscles. So proliferation, because this is estrogen dependent. মানে যদি sporadic হয়, this is estrogen dependent. And if this is not sporadic, this is associated with tuberous sclerosis. So in case of LAM এ কি হয়? LAM or other bullous disease অনেক কিছু আছে. Bullous মানে হচ্ছে bulla. What is bulla? This is a potential air containing space. So শুধু COPD তে কিন্তু বুলা হয় না, আরো অনেক কিছুতে বুলা হতে পারে, or cyst formation হতে পারে. Rather you can call it cyst. কোথায় cyst হতে পারে? কোন লাং ডিজিজ cyst হয়? এই একটা হচ্ছে causes LAM, lymphangioliomyomatosis. Second is LCH, Langerhans cell histiocytosis. So these two are the most common causes of, and LIP also, lymphocytic interstitial pneumonia. These three causes are the most common causes of cystic lung disorder. So কি হয়, এই সিস্ট গুলো, এই কথা বলিস না, কথা বলে আমি হচ্ছে না, কনসেন্ট্রেট করা যাচ্ছে না. So these cysts of the LAM and LCH are very thin walled, খুব পাতলা হয় ওয়াল. So even after a small exertion, the cyst may rupture, causing a pneumothorax, and there is recurrence of the pneumothorax because there are multiple cysts. এই প্রসেসটা তো কন্টিনিউয়াস প্রসেস. সিস্ট তৈরি হচ্ছে, আবার রাপচারের নিউমোথোরাক্স হচ্ছে, আবার সিস্ট প্রোডাকশন হচ্ছে. সো নিউমোথোরাক্স ইন টিউবারকুলোসিস, মোস্ট কমনলি ইন ক্যাভিটারি টিউবারকুলোসিস. নেক্সট, মোস্ট ইম্পর্টেন্ট ইন এমার্জেন্সি ম্যানেজমেন্ট, দ্যাট ইজ টেনশন নিউমোথোরাক্স. সো হোয়াট ইজ টেনশন নিউমোথোরাক্স? যেটা আমি এখনই বললাম. ইয়েস, দেয়ার ইজ এ ভালভ লাইক অ্যাকশন. বেসিক্যালি দেয়ার ইজ এ ভালভ. দ্য ভালভ ইজ ওয়ান ওয়ে ভালভ which allows the air to enter during the inspiration but cannot evacuate the air during the expiration. That means there is progressive accumulation of the air inside the thoracic cavity. Pneumothorax is in tension. This is called tension pneumothorax. So intrapleural pressure is more than atmospheric pressure during the expiration. Okay? And as the tension pneumothorax grows, there is increased intrathoracic pressure, collapse of the lung, collapse of the alveoli, and mediastinal structure as well. ঠিক আছে? That is the medical emergency. This is not because of the lung itself, because of the cardiac structures or because of the mediastinal structures. So most common etiology হচ্ছে giving a positive pressure ventilation. We are giving external positive pressure. ঠিক আছে? একটা উইক লাং, সাপোজ the lung is friable, the alveoli are friable enough. In case of COPD or any chronic lung disorder, the lung is friable. So যদি পজিটিভ প্রেসার বাইরে থেকে দিই, তাহলে কি হবে? ওই পজিটিভ এয়ারের প্রেসারের জন্য alveoli, friable alveoli will rupture, right? And যদি তুই ফলো না করিস পেশেন্টটা যদি ফলো আপ না করিস, পেশেন্টটা যদি সিরিয়াল এক্সরে না করিস, you may miss the pneumothorax in initial stage. তার ফলে আরো পজিটিভ প্রেসার অ্যাকুমুলেট হচ্ছে, that leads to tension pneumothorax, right? So during expiration, the air traps inside the pleural cavity, increasing intrapleural pressure. So this cycle repeats. In each breath or in each respiration, the pressure accumulates. So why this is a medical emergency? যেটা আমি এক্ষুনি বললাম, because of the compression of the mediastinal structure and the cardiac chambers, decreased cardiac output, decreased venous return followed by decreased blood pressure causing hypotension and shock and cardiac failure. So that's why this is a medical emergency. So clinical examination is very important. তুই কোনো পেশেন্টের টেনশন নিউমোথোরাক্স হলে এক্সরে করলি, মানে কোনো অ্যাসার্টাইন হতে পারলি না, তুই এক্সরে করলে, বাট টেনশন নিউমোথোরাক্স কিন্তু will never give you the adequate time. Before that, the patient may expire. So you have to be very cautious ডিটেক্টিং টেনশন নিউমোথোরাক্স। সো টেনশন নিউমোথোরাক্সের কিন্তু ডায়াগনোসিস করতে হবে ফুললি অন বেসড অন ক্লিনিক্যাল সাইনস অ্যান্ড সিমটমস। There will be severe shortness of breath, there will be tachypnea, tachycardia, hypotension, and most importantly cyanosis. Cyanosis is only present in tension pneumothorax, not in other pneumothoraxes, right? And also there is increased JVP. This is very important. Increased JVP because of the pressure in the right heart. So trachea deviated to the opposite side. এটাও কিন্তু ইম্পর্টেন্ট, অন্য কোনো নিউমোথোরাক্সের ট্র্যাকিয়া ডেভিয়েট হবে না except this is a case of tension pneumothorax. Rapidly the patient progresses to shock. তাহলে কোনো পেশেন্ট এলো খুব ডিস্ট্রেস হচ্ছে, সায়ানোসিস আছে, জেভিপি দেখলে জেভিপি রেস্ট, মাস্ট হ্যাভ টু অসকাল্টেট দ্য চেস্ট অ্যান্ড পারকাস দ্য চেস্ট। যদি সঙ্গে সঙ্গে তুই সাজেস্টিভ অফ নিউমোথোরাক্স পাস, দেন ইউ মাস্ট ইন্টারভিউ। So this is tension pneumothorax. The trachea is deviated to opposite side and the diaphragm is also depressed. That steepening of the diaphragm, right? So diaphragm is also depressed. So this is emergency. You have to do the emergency management. First you have to secure the ABC, airway, breathing and circulation, just like other emergency managements. Then the most important is immediate needle decompression. Chest tube arrange করার জন্য অনেক টাইম লাগবে, so you have to decompress the pneumothorax urgently by putting a needle where আগে recommendation ছিল in second ICS, but now it is recommended to put a needle in fifth ICS. ইন সেফটি ট্রায়াঙ্গেল, যদি না সেফটি ট্রায়াঙ্গেল লোকেট করতে পারিস যে কোনো একটা এরিয়াতে ফিফথ আইসিএস এ ঢুকে দিতে হবে, ঠিক আছে? সো আফটার পুটিং এ নিডল দেয়ার উইল বি এ প্রমিনেন্ট হিসিং সাউন্ড, একটা খুব মানে যেহেতু দেয়ার ইজ এ টেনশন, ইনক্রিজ টেনশন ইনসাইড দ্য প্লুরাল ক্যাভিটি, আফটার ইমিডিয়েট রিলিজ অফ দ্য প্রেশার দেয়ার উইল বি এ গাস অফ ফ্লুইড দ্যাট রেজাল্টস ইন হিসিং সাউন্ড, সরি ফ্লুইড এয়ার দ্যাট রেজাল্টস ইন হিসিং সাউন্ড, একটা শো শো করে একটা এয়ারের মতো সাউন্ড আসবে, দ্যাট ইজ দ্য কনফার্মেশন অফ দ্য টেনশন নিউমোথোরাক্স, রাইট? সো আফটার ইউ পুট এ নিডল, তাহলে কি হলো, কিছুটা ডিকম্প্রেশন হলো, বাট ইউ হ্যাভ টু ডু দ্য টিউব thoracostomy or put a ICT, right? So in the same place in fifth ICS, but most importantly কি করবি না, নিডল কখনোই উইথড্র করবি না আনটিল এন্ড আনলেস তুই সিকিউর করছিস তোর আইসিটির পজিশন, বিকজ নিডল উইথড্র করলে আবার রিঅ্যাকুমুলেশন হবে, ঠিক আছে? আইসিটি দিয়ে দিলি, তারপর নিডলটা উইথড্র করে নিলি, ব্যাস, ঠিক আছে?